Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and associate professor at the Duke University School of Nursing. I'm so happy to welcome you into our first series of 2026 with an episode that reviews the 2025 measles outbreak and our current evidence on how to recognize, diagnose, and treat measles. First, I wanted to start with my disclosures. I do not receive any financial incentive to distribute this podcast. Not a single red penny. Why would I do this? Because this is my form of advocacy, and I want you to be sure that this podcast is free from conflicts of interest or any secondary gain that could limit the credibility of my work. I'm so invested in credibility that I have 2 independent peer reviewers evaluate each episode before publication to keep an eye out for any areas that may represent bias or other conflicts and ensure the content is accurate and correctly referenced. That kind of quality assurance does not happen in all podcasts, but it means that the Peds NP is one you can trust. A link to the peer review process is in the show notes, or you can find it on the website at thepedsnp.com and click peer review. Now let's get started with our measles update. I'll be reviewing a wonderful article from the New England Journal of Medicine that was published in June of 2025 by Doe and Mulholland. I'll also cite a recent article written by myself and John Lyles about post-exposure prophylaxis and treatment in children with inflammatory bowel disease. Check out the references in the show notes for links to the full article. All right, let's get started. Measles, or rubeola, for those of you who are trying to remember your old school notes, is a highly contagious respiratory virus that is potentially lethal. Truth be told, I've never seen it in practice because the United States led a successful 2-dose MMR vaccination program in the 1990s that led to its elimination in the U.S. in the year 2000. I then came along in an era of measles elimination and had no idea what a privilege it was. But the recent COVID-19 pandemic, rising vaccine hesitancy and refusal, and accessibility issues have led to declining vaccination rates among U.S. citizens, which caused 49 outbreaks last year that we never really got under control and now threatens the U.S.'s elimination status. Let's pause real quick and define elimination. When a disease has been sufficiently diminished in a geographic area for 12 months or more, while a robust surveillance system monitors the presence of any spread, a disease is considered eliminated. Conversely, eradicated is when the disease no longer exists, like with smallpox. Eliminated means that it may still happen in isolated circumstances, but it's not spreading thanks to interventions like quick quarantine and public health efforts. When infection spreads despite these efforts, the clock starts ticking, and when there is sustained transmission for over a year, elimination status is lost. Loss of elimination status is a major alarm bell because not only does it signal a public health instability in the face of vaccine-preventable diseases, but it also foreshadows the immense expenditures that we will be forced to pay to contain outbreaks. Among those costs is the loss of life. Measles is spread through respiratory droplets, and it's so contagious that even one single person who gets infected is expected to spread the virus to 12 to 18 additional people if they aren't appropriately quarantined. Data for our ongoing measles outbreaks in 2026 show that our numbers this winter were 4 times what they were at this time in 2025. And that's because infected people with the virus can transmit it for 4 days before and 4 days after the eruption of the classic cephalocaudal measles rash. So once you identify the rash, hindsight is going to showcase the dozens of exposures that have likely happened when the viral prodrome was just getting started. Let's remember what that classic viral prodrome is. You remember the 3 C's: cough, coryza, and conjunctivitis. And here's the kicker. Nearly 75% of the cases are in pediatric patients. So this is an extremely important topic for this podcast. Just think about it. How common is it for children to have these symptoms? Cough, runny nose, red eyes. That sounds like a daily visit to any daycare or elementary school. And it's a common presentation to primary care offices, urgent cares, and emergency departments. And yet, the people who are evaluating and diagnosing this disease are predominantly from a generation who only learned about measles in books. Actual books, because iPads hadn't even been invented when I was in graduate school. I've never seen measles outside of a lecture slide. Measles was a test question to memorize, a classic syndrome not to miss that would earn an extra 2 points on the exam. But in reality, its return will lead to so many more hardships. School closures, lost productivity from parents staying home with kids, isolation and quarantine, or hospital costs. So you're probably asking, how am I supposed to identify it in this outbreak? Well, I'd say the first and simplest and most important step is to assess a patient's vaccine status. Because we know from the 2025 and 2026 data that 93 to 94% of those infected were totally unvaccinated. Even just having one dose of MMR was protective, because we can see that the number of people infected who had one dose of MMR is nearly equivalent to those who had breakthrough infection after 2 doses of MMR. Next, you should be wary of measles in any child who is missing 1 or more MMR vaccines who presents with fever and prodromal symptoms, which includes diarrhea, according to Doe and Mulholland, because diarrhea can last for up to a month in the acute phase of the virus. Then, if Koplik spots erupt, you know that these pathognomonic white spots on the buccal mucosa are a forewarning of the erythematous maculopapular rash that spreads from head to toe. I want to highlight real quick for my acute care colleagues out there that unvaccinated children and immunocompromised children are at greatest risk of severe complications from measles, and immunosuppressed individuals may not present with classic symptoms, yet are at risk for disseminated disease. Measles spreads like wildfire because it is so contagious and it requires herd immunity of at least 95% to protect those few instances of unvaccinated people who are typically children under a year of age or those who medically aren't able to. But with rates dropping down to the high 80s and low 90s from non-medical exemptions, pockets of infection quickly lead to outbreaks in communities with poor vaccination rates, which is most dangerous for those small children and those who are medically ineligible. And for me, this feels a little bit like the Wild West, a frontier of total unknowns, because I have never practiced recognizing measles, and I'll be honest, it's not necessarily at the top of my differential when I see those early symptoms, but it needs to be. In the decades prior to vaccine availability, measles infected over 500,000 people each year. And remember, as a systemic disease, it's going to spread through the gut, the eyes, and the respiratory system. So it's not a surprise that 30% of individuals are going to develop some kind of complicated disease. In our 2025 data, 18% of children infected with measles were hospitalized. That's nearly 1 in 5 children are going to be hospitalized. And those diagnoses were things like pneumonia, otitis media, diarrhea, acute encephalitis, blindness. It can also cause long-term immunosuppression and even death. And again, that's typically going to occur in children under 5 years of age. Let's hit a hot topic in the media. blindness and vitamin A deficiency. So, blindness is associated with corneal ulceration that occurs in children with vitamin A deficiency, which is most common in low and middle income countries, where the children's nutritional status leads to a deficit in essential vitamins and minerals. In fact, 45% of fatal cases of measles noted that malnutrition was a contributor to the lethality of the disease. But vitamin A deficiency is relatively rare in the United States. It really only affects around 1% of the population because we have really good nutrition in our country. But you know that I always like to point out the acute care perspective, and there are some children that are at risk for deficiency that we need to be considering. So children with cystic fibrosis who can't absorb fat-soluble vitamins very well, children with Crohn's disease and ulcerative colitis in about 25% of cases will have some kind of malnutrition, or those who were recently diagnosed with celiac disease. And it makes you think, this is a great call for prevention, right? We should all be on vitamin A. Not exactly. While vitamin A supplementation is recommended for all people infected with measles to reduce complications and the risk of death, it does not, and I repeat, vitamin A does not prevent measles infection. A 2022 Cochrane review of 6 clinical trials concluded that vitamin A supplementation did not affect the risk of death due to measles. You want to know the best way to protect against measles infection? It's a 2-dose series of the MMR vaccine. After rigorous study, the MMR vaccine has an extremely safe vaccine profile and is highly effective. A single dose protects 93% of recipients from infection, and 97% are protected after 2 doses. Unfortunately, misinformation spread by a now debunked study that linked autism with the MMR vaccine, along with other anti-vaccine campaigns, has led to a loss of confidence in the MMR vaccine and an overall decline in childhood vaccination in the United States. When scientists modeled a 10% drop in MMR vaccine uptake, they stated that it could cause 11 million measles infections in the U.S. over 25 years. And when you factor in complication and fatality rates for measles, remember, around 1 in 5 children are going to require hospitalization. That means millions of hospitalizations and tens and thousands of deaths. And then zoom out and think about the even bigger picture. The efforts needed to simply control those wildfires means that we're going to lose ground on other public health efforts, such as other infectious disease threats like flu, for example, chronic disease management, maternal child health, and emergency preparedness. Oh man, that is so much doom and gloom. I'm sorry, but I just had to be real for a minute. And now we can transition to what you need to know as an individual provider and what you can do to protect and support kids. So first, we are going to be vaccine advocates. Advocacy is education. And you don't have to make a poster or stand on the steps of the Capitol to be an effective advocate. Sometimes that advocacy, that education, comes in one-to-one form with motivational interviewing. Being a trusted person in the room to dispel myths or offer clarifying information is a critical component of advocacy that you can offer to an individual child. Another way you can advocate is through ensuring that we have complete documentation of their MMR vaccination. This includes confirmation of a completed MMR series in either digital registries, the electronic medical record, or caregiver-provided documents. The Advisory Committee on Immunization Practices, or ACIP, and the American Academy of Pediatrics recommend that immunity against measles be confirmed through simple documentation of MMR vaccination rather than serologic testing, given the high false negative rates of titers. In simple terms, the titers are often inaccurate, so you don't need to test for antibodies to confirm their immunity after vaccination. So, remind me, when do these vaccines happen again? I recommend that you start to follow the American Academy of Pediatrics vaccine schedule if you're not already doing so. They have safe and evidence-based recommendations for the age at which to first vaccinate. Infants get their first MMR vaccine at 12 to 15 months and again at 4 to 6 years. If a child is traveling internationally to an endemic country, they recommend getting MMR for infants 6 to 11 months old at least 1 week before travel. So when my son was 7 months old, we decided that we were going to go to a music festival that my favorite band was hosting in the Dominican Republic. So he got his MMR vaccine along with his regular 6-month vaccines. And that meant that he was sitting beachside with his little baby headphones, and I was head bobbing to my favorite band, confident that I had given my baby the added protection that he needed in an endemic country. A key point to remember is that those infants will still need their regular 2 doses at the recommended ages, with at least 4 weeks in between doses. All right, what about the MMR plus varicella vaccine? I love this conversation because it is super nuanced and it's a real conversation. The MMRV vaccine is known for causing high fever and a delayed fever. It happened, in fact, to my daughter after she got her 12-month vaccine, and it was really tough because we had been battling ear infections for months already, and we were doing a watch and wait otitis, which she failed, and so we ended up starting the amoxicillin, but then boom, out of nowhere, she gets this really high fever. So I couldn't tell, was it the vaccine or was she failing amoxicillin? And sometimes I just need to be a parent and not a provider. So we went in for a visit and it turned out that her ears were great and it was just this late onset fever. And there was nothing for us to do except supportive care. I want to clarify a point before we go on. MMRV does not cause febrile seizures. About 2 to 5% of kids will get febrile seizures independent of the MMRV, and this might just be their first really high fever that sparks that. So because of this high fever caused by the MMRV, there's a chance that they're going to have their first febrile seizure, which is more common in the younger ages in comparison to when the second dose is given at 4 to 6 years. By 4 to 6 years, they've definitely had a really high fever at some point in their life. So it ends up being a discussion that you want to have with each family. They have 2 options. Option 1 is get the MMR vaccine and varicella vaccine separately. That means 2 shots, but there's a lesser chance of the high fever. Option 2 is give the MMRV vaccine combination 1 shot, but there is a calculated risk of uncovering the 2 to 5% of children who will develop febrile seizures. The AAP has no preference, so it really comes down to what the family feels more comfortable with. I chose to give separate MMR and varicella vaccines at 12 months and give MMRV together at 4 years. So what other forms of adaptive immunity exist? Well, maternal antibodies transferred through the placenta and breast milk are a great form of natural passive protection for the first 3 to 4 months. But then maternal antibodies start to fade and babies can be at risk, especially when they're in an endemic area. This is one reason why the U.S.'s elimination status is such a big deal. Let's think about it in the context of the world. Other lower middle income countries with higher endemic rates actually lowered the age of first vaccination to as low as 6 months. But even if you lower the age of first vaccination, there's still a 2 to 3 month gap in immunity, which means that we're more likely to see infants who are too young for immunization get sick. And why is that important? Children under age 1 have the highest mortality rate. The good news is that after regularly scheduled doses, healthy children have no waning immunity. Even children who develop chronic diseases like inflammatory bowel disease and use immunocompromising therapies are still protected. An asterisk for my hemonc friends out there who care for high-risk, severely immunocompromised children who have received chemotherapy or a stem cell transplant. These patients lose their immunity, and the guidelines recommend that they are fully revaccinated after completion of therapy. Remember how I was pointing out that us elder millennials have never seen measles and took for granted our good fortune of vaccine acceptance throughout our early training? We never considered that we could return to a new era of vaccine hesitancy and refusal. And that's just the conundrum my husband encountered when he was sitting in his clinic for children with inflammatory bowel disease. The parents of his patients, visit after visit, came in worried about measles exposure in their immunocompromised children. The children with IBD were getting infliximab, and they worried that travel to places like South Carolina or Texas, where measles cases were exploding, meant that their child was in danger. He spent hours upon hours poring over the evidence on how to manage a child who had been exposed. And being the good academic wife that I am, I told him, you should write a clinical guideline to support clinicians with the same question. And well, fast forward, we put the kids to bed and sat on the couch night after night picking apart the idiosyncrasies of disease-specific risks and treatment to bring you an article in the Journal of Pediatric Gastroenterology and Nutrition called Prevention and Post-Exposure Prophylaxis for Measles in Children with Inflammatory Bowel Disease. Here's what I want to highlight from our article. Biologics such as infliximab revolutionized the treatment of pediatric IBD since the early 2000s, while measles was eliminated. But most of these biologics are considered high-level immunosuppression, and they render patients functionally immunocompromised, which is not a problem until a highly contagious infectious disease that was once eliminated resurges in your country. So, what should acute care providers do when they care for a child on one of these drugs? Well, first, as I said before, make sure you assess their immune status, ideally at diagnosis, before any immune-altering drugs are started. If a child has not been immunized, offer the strong recommendation to hold off on initiation of therapy if possible and get vaccinated, and encourage all of their family members to do the same. Although vaccination does not guarantee complete protection against infection, it often attenuates disease. Children receiving high-level immunosuppression should mitigate their risk of exposure to measles as much as possible, such as avoiding travel to areas with outbreaks or endemic disease. And if travel is necessary, they should protect themselves by masking up, using an N95 or KN95 masks in public spaces to help avoid droplet exposure. Should a child receiving immunocompromising therapies be exposed, there's a great table in our article that visually guides you through their post-exposure prophylaxis and treatment, which can vary between MMR vaccine, immunoglobulin, supportive care, and home quarantine, depending on the child's age and level of immunosuppression. Let's review what you can do as a pediatric provider to be better prepared for the current measles outbreaks in your area. First, assess the immunization status of your patients. Next, also assess their travel history, both international and within the United States, to areas with known outbreaks. Then, don't forget to include measles on your differential diagnosis, particularly in children with fever who have a known deficit in their immunization status, whether or not they have a rash or not. Treat measles cases with supportive care and quarantine, and follow post-exposure guidelines for children who are eligible. Lastly, have honest and empathetic conversations with families of unvaccinated children, using motivational interviewing to encourage vaccination. I feel like I've really watched vaccine discussions evolve during my career since becoming a pediatric nurse practitioner. Extensive research has confirmed vaccine safety and efficacy, but ever-present concerns from hesitant caregivers means that we should always leave biases at the door and put children at the center of the conversation. I hope that you'll leave here today more confident, not necessarily in recognizing and diagnosing measles, because unfortunately, we are all going to need some practice before that gets incorporated into our skill set. But I want you to be confident in how you discuss safety and efficacy in the MMR vaccine, the risk of measles, especially in young infants and immunocompromised individuals. And I want you to be confident in the power that your relationship with families wields to influence their comfort in accepting the MMR vaccine. Let's continue the conversation on LinkedIn, Instagram, or by email at thepedsnp@gmail.com. Like and share this episode with a friend to increase the reach of this important message. And remember, this isn't just a podcast. You're building vaccine confidence, one conversation at a time. I'm Becky Carson. Take care.